Hey everyone, welcome to another edition of the Right Way Wednesday. Today I have Loretta with me from the Clinical Strategies Division, and we're going to talk about the quote-unquote challenging patient. We've all had them. We have all had a patient where we have just maybe been at our wit's end. Maybe they're constantly refusing, or maybe they're just not participating in the way that we expected, or we hope that they will, or we feel like they need to be, for whatever reason that might be. And so sometimes it's easy to label them as challenging rather than to really sort of dig a little deeper and try to figure out what's going on with them. And we always say that really, with patients, we are supposed to be giving them the best possible care, right? And based on their particular needs. And sometimes that can be difficult depending on who we're working with. So Loretta does a lot of training and research, and she is our guru for patients who are living with dementia. She is just our resident expert on all things that have to do with that. And so just one of the things that she talks about a lot about is working with that quote unquote, again, challenging patient. So one of the things you talk about, Loretta, a lot in your trainings and when you're out there in the field is using that therapeutic role of self. What exactly do you mean by that? What does that mean? What does that look like?
Sure. So therapeutic use of self is really being aware of oneself, you as the clinician, and how you are integrated within that patient-therapist relationship. It's being aware enough so that you're able to control how you communicate and interact within that relationship. It's also, I always say, you have to recognize that the patient-therapist relationship is not an equal one. There's always that expectation that we're there to help the patient's not there to help us. And we need to be able to recognize that because of that unequal playing field, we have to bring more to how we enhance that relationship. So, I always say, if we're aware of that, it allows us to more effectively identify problems, set goals, come up with those thoughtful interventions that help us get to those desired outcomes. And ultimately, that's what we always want to do, right? We want the patients to get better. So I think therapeutic use of self is that. And then within that, we need to recognize that as a therapist, we take on many roles. I always talk about we're that instructor, we're the coach, we supervise the person doing something, and we help problem solve along with that patient. And then ultimately, we're a role model. And so by being that role model, it kind of lends itself to that therapeutic use of self.
Okay, that's great. Yeah, absolutely. One of the things that I see sometimes in documentation, and I hear clinicians talk about a lot, and I've probably written myself and thought myself, is the idea of trying to deal with a patient's negative behaviors. I wanted to talk a little bit about that in our role in adapting, basically sort of just building on what you just said about, our patients aren't there to help us, we're there to help them. So when we identify a behavior that we're perceiving as negative, what is our role in response to that and trying to sort of get out of that process?
Sure. I think the first thing we need to do is we need to step back. And I think I want to just backtrack a minute because I want to just talk about some of those skills that we need to be aware of within that relationship. One of them I always talk about is empathy. We have to have that ability to understand where that person is coming from, what their feelings are. I always say it's Atticus Finch from To Kill a Mockingbird always said, you have to take a moment to walk in somebody's shoes. And sometimes, we realize we treat seniors every day. It becomes second nature. But for that individual, this is maybe the first time they've ever interacted with a therapist. And that brings a whole plethora of different emotions, and we need to understand that. Being sensitive to that person's needs, how we, not only their needs, but how we affect them. I always use the example of, we're very busy. Every minute counts, and we rush from session to session. And sometimes, we're not even taking into consideration. We're already thinking of our next patient, and we're kind of not totally there with that patient. And that's that sensitivity part that needs to be involved. The next one is respect. I think we, as most clinicians, we truly are committed to our patients, and we say, yeah, I respect my patients, but we have to also see them as unique individuals. And something that I cringe so many times when I hear clinicians refer to patients by their diagnosis or their deficit area, and how it kind of erodes on that relationship. And we don't even pick up on the fact that other patients are watching that happen too, and what it does to our relationship. And then the last one is also just that warmth, that sometimes just making that nuanced, touching somebody, smiling in their presence, giving them a thumbs up, all of these things kind of contribute to that therapeutic use of self. And as you were saying, I think the most important thing we need to understand is that so many times our patients come to us at a time when they're so vulnerable. They've had a life-changing event, a catastrophic illness, an accident. They've had an exacerbation of a chronic illness, and obviously a functional loss. And what does that do to the patient? Well, sometimes what happens is that sense of loss is manifested in, like you were just talking about, they become resistant, or they have increased anxiety or worry, or they get angry and frustrated. And one of the things I always talk about is that so many times, when that you have that sense of loss, and just think about when you've experienced a loss. Sometimes the only thing our patients have left is the ability to say no. And they say it. They go, nope, I'm not doing that. Even though intellectually they know they're here to be in this process because they want to get better, but because they're struggling so much that they feel like, hey, you're telling me what to do, my body's not listening to me, the only thing I have left is say, nope. And they do it time and time again. So being able to be aware of where that starts from and recognizing it is so, so important to that therapeutic relationship, and helps to enhance that skill set as a therapist.
Yeah, as you were talking, I was just sort of thinking about to my days out in the field and thinking about those times where I realized I had brought in my anxious or negative energy into the room. And especially when we're, those patients who are vulnerable, or, those patients who are living with dementia, they feed off of whatever energy is around them too. And, what we might perceive as a negative behavior, right? And you talk about this all the time, I know, is it's really a way for them to be communicating with us in a way that they maybe can't communicate with us verbally anymore, right? So those kinds of behaviors too, I mean, it's our role and responsibility to figure out why that's happening. I remember as a clinician, sometimes I would have to step out of the room, take a breath, sort of assess what just happened, and then step back in with a whole different attitude and approach. And that was one of the things that I did to sort of manage the energy that I was bringing into a space at any given point. Yeah.
And I think it's so important. I think, again, back to, as therapists, we have to manage a lot and we juggle a lot. And it's hard. But we're human. We're human. Yeah. And when somebody is telling you you're the worst thing that ever happened to them and they hate you, it's really hard to say, oh, well, thanks. No, I mean, you really, you want to say, oh, I wish I could just leave and never come back. And, so I think sometimes it is hard because we're humans also. We have feelings. But like you said, we've got to take a step back. It's maybe talking through with one of your coworkers and kind of saying, help me to understand this. But also, taking a breather and starting over, and sometimes we tend to rush through this part of the relationship. I see that happen so many times. We don't see this therapeutic use of self is just as important as an intervention than a neuro re-ed or a balance test that we're going to do with this patient. Because if we don't have a solid foundation and that patient doesn't trust us, we never get to the level we want to achieve with that patient. And that's why I think it's so important as therapists. We're quick to want to label. This person is annoying, or this person is non-compliant, or all they do is complain, or, but we have to say, okay, why? Why is this person doing this? And then helping them through that. And it's hard. And it's not saying it's not easy. And there's sometimes we fail. We never get there, but we have to understand it's a barrier. It's a barrier just like somebody who has poor strength or low endurance. It's a barrier, and we have to see that we have to address this just as effectively as any other issue the patient has.
So let's talk about how we document that particular barrier,
Sure.
because that's one of the things that we see a lot. And of course, that is the focus of our page here, and our viewers know this. When we document things like resistive to treatment, or patient with negative behavior today, or patient refused, or whatever that might be, reviewers will sometimes call us out because they say, well, your patient is refusing, they're clearly not working with you. Our documentation doesn't necessarily reflect maybe the strategies that we're using, or why the patient might be behaving that way, or showing those types of, again, perceived negative behavior. So what kinds of things should clinicians be documenting, so if they get that patient who they are having maybe difficulty reaching or difficulty engaging in therapy, how do we document, first of all, what that barrier is, and then how do we address it, and how we're addressing it in our documentation so that we can still justify the skilled need?
I think that's a great question. I think, again, is taking that step back, and instead of just labeling the patient refused, or the patient is complaining, or the patient is uncooperative, we need to be able we can state the behavior, okay, but then we need to interpret it. So it appears to be as a result of fear, anxiety, depression, mood, lack of engagement. And then our role is, then you need to be able to connect the dots. What are you as a therapist going to do to allow or to address that? So even saying something, allow patient time to verbalize fears, or therapists acknowledged with patients that this is very overwhelming, and then what you're going to do about it. So breaking down the task, maybe looking at and getting them to reassess the goal that they want to work on. Now, of course, for dementia patients, that's a little difficult, but we see this type of behavior even in our orthopedic patients, that have no cognitive deficit.
Yeah.
Right. So being able to connect those dots, that's what we bring to the table. We have the clinical skills, the clinical reasoning to be able to pull, to be able to interpret that behavior and then make a determination of what we're going to do. It's not any different than when we say, Loretta's got shoulder pain, and this is what I think is contributing to the shoulder pain. Well, in this case, Loretta is refusing to get out of bed, okay? And I've got to figure out why. And is it fear?
Right.
I always use an example. I had a patient one time, which was, I was the OT and the PT. We were actually co-treating together. My PT was 4'9". Okay, this patient was 6'6". He had a new stroke, and as soon as he saw the PT, he was like, "No way, you are not touching me. I'll let this big lady over here touch me because she's got more substantial size." And initially, the PT was quite taken aback, like, he doesn't trust me. And I said, no, we've got to get him to see that you have the skill set, but he's just making an interpretation based on your size. And we've got to be able to recognize that. Mm-hmm.
Yeah, that's right. Loretta, I think this is something we could probably talk about for hours and hours, because I think there are just so many variables to our patients. They are people just like us, and they have these emotions that they're grappling with, the loss of control, medical issues abound, right? But I think it's a great discussion. If anybody has any tips we would love to hear about them in the comments below. If anybody would like to ask questions of Loretta or myself, please again ask in the comments below, or just send us a separate question by submitting a comment. We would love to hear from you. Thank you so much, Loretta, for your time. I really appreciate you talking with me today.
Yes.
Thanks, guys, and happy documenting.